A very good afternoon to everyone. Thank you all. So we resume this webinar, which is focused on brain infections. We've themed it as Let's Talk Brain Infections. So this is a part of the ICMR-funded Center for Advanced Research project, which focus on studying the impact of climate change on brain infections. So this is an educational initiative where all the 10 Sentinel supporting centers of this project take up each month and discuss about one important brain infection, which is very important for all the clinicians to know, as well as on the diagnosis and multiple aspects of it to increase the awareness among the clinicians. So it's a we're very honored and very privileged to have the team from NEIGRIHMS Shillong to actually lead this month with the theme of cryptococcal meningitis, which is actually quite a devastating brain infection and which is in India is quite endemic for this disease. Previously thought to be more of a disease of the HIV. Now the HIV is actually hardly there. But we're still seeing a lot of cases in immunocompetent, which means that this is one of the part of the environmental and acquisition, and all of us are predisposed to it. So it's very important that we know how to recognize as well as treat this disease, because though they present in a different ways and different forms, it is potentially treatable, and there are so many patients who have treated and who have been treated and have done well. So may I take this opportunity to introduce Dr. Bayak Menlang Singmon, who's a associate professor in neurology at NEIGRIHMS Shillong. She's our esteemed co-investigator of this ICMR CAR project. And we also have the esteemed moderator, Dr. Ravindra Kumar Garg, who's a pioneer in a lot of diseases, especially related to infections. Sir has a vast number of publications in multiple fields. We are very honored to have Sir here. We also have Dr. Dabeth Ringa, who's in the team of NEIGRIHMS Shillong, who will be discussing the diagnostic and the microbiological aspects of this disease. So thank you all. And we hope even if less people attend this, there is a lot of people who actually look at it later in the YouTube, because we record the whole conversation and put it in YouTube so that people are not able to attend it, listen to it later, and they gain knowledge out of this. So thank you for spending your valuable time and supporting this initiative. Now over to the NEIGRIHMS team, Dr. Sinmon, for the talk.
So thank you, Dr. Angel. So this entire month is dedicated to cryptococcal in Let's Talk Brain Infection. So we'll be having three aspects on it. I'll be just trying to touch the pathogenesis and the clinical manifestation. Dr. Dabet will be trying to help us to understand how to make a diagnosis at the earliest. And later in the end of the month, one of our faculty, Dr. Mahendra, is also a part of this project, will be teaching us about the treatment. So without further delay, I think it's if we can start the so I think my slides is showing now.
Yes, you can
put it in.
Yes, ma'am.
Yeah, so we'll be talking about cryptococcal, just a little bit about the pathogenesis and its clinical manifestation. So my disclosure is I have taken this slide mostly from the PubMed articles that have been published and from few speakers, renowned microbiologists. So we'll be talking on these few aspects as I've listed down in the slide. So initially, when cryptococcal was first found, it was found from a discharging pus sinus of a 32-year-old female from the tibial bone. That was by Abraham and Otto. Later during that year, the same organism was detected from a fermented peach juice. And that time they labeled it as Saccharomyces hominis. But then later, Jean Paul in the year 1901, he said that this is a little different organism as it do not develop ascosphere. So he named it Cryptococcus neoformans. But it was Dr. Chung who helped us a lot to understand the various species, the sexual formation of this organism, and the pathobiology of the two most important pathogenic Cryptococcus. So with that, initially when cryptococcal was diagnosed, it was a not toxo infection because of the less amount of patient, like 100 or 150 per year. But when HIV or AIDS have made it to the news in 1983, then the CDC has defined this disease being as one of the disease-defining illness in AIDS. It was then that cryptococcal had picked up the diagnosis and was creating a chaos in the world, and also one of the leading cause of death. But over the years, if you see, cryptococcal has definitely come down. So is it still, a threat only to the a neglected tropical illness or subtropical illness, or has it become a global threat to the human health? So we see that overall, over the years, cryptococcal has come down, but the mortality that it causes has not come down. It is still one of the leading cause of death in AIDS related. And secondly, we notice that this disease has started emerging in certain other areas, temperate zone climate. So this shows that there's some changes that the organism has adapted over the years. So that means there is something to do with climate on this infection. So when we talk about this infection, we know that this is an environmental fungus, so we need to know very well about its habitat. So many species are there, but we usually talk about these two species. So the habitat of Cryptococcus neoformans, they are said to be pigeon dropping, especially the elderly pigeons. So in the soil, in the decaying plant matter. Whereas the Cryptococcus gattii is said to be found in decaying wood, the hollow woods, the eucalyptus tree. This tree that I have kept in the site in Africa was very common. They found a lot of Cryptococcus gattii in beneath this tree. So the thing about this yeast is that it's an obligate aerobe. That means it needs oxygen to survive. But it has a capsule, and this capsule is something that helps it survive in soil. So in condition where there's less oxygen, this capsule changes. It becomes increase in size and protects it from the less oxygen condition. So it has a dynamic capsule that helps it live in the environment. So if you see, as I have said, over the years, the disease is now emerging in certain temperate region. To back up this, people have started doing some studies whether this, pathogen can live in extreme of temperature. So these are just two articles that I have kept here. On extreme very high temperature or on extreme very low temperature, Cryptococcus can survive. So this shows that this pathogen is very notorious and is able to survive on either extreme grade of temperature. What about the natural, environmental distribution? Has there any study been done in India? So this is one of the study that I've picked up. They tried to investigate and take samples from the environment, and they found that they have seen more cryptococcus in the hollow tree trunk, on the soil of these area like Delhi and Rajasthan. So, was any study conducted in Northeast India? There was a study conducted in Northeast India on the Assam. So, in this, what they did is they went to these attics and they scraped off the poop of the pigeon birds. So, they went to the attics, the contaminated soil, the eucalyptus tree, and they also took droppings of other birds. So, what they found that they found Cryptococcus species, but they never found the pathogenic Cryptococcus species. Second thing, they found that the dry specimen had more better ecological sustenance for this pathogen compared to the moist. So this shows that just like Dr. Angel said, this is available in the environment and we are exposed to it all the time. Then came the saying that kids play more with birds, kids play more, in the garden. So are the kids more exposed? So, one person, Dr. David Goldman, what he did is he examined 185 serum of children who are asymptomatic, and he cross-react them whether they are reacting to any protein of the cryptococcal. He took people who had cryptococcosis or who are working in laboratory dealing with cryptococcal as to compare them, and he found that there is a lot of cross reaction, especially in children beyond 2 years. And among all these children, there was only one children who had symptomatic, who presented with cyclical vomiting in the hospital. Then came the newspaper that our children are being poisoned, which has raised a lot of problem during that era. But then later, this case report showed that this infection is not only with the pigeon birds outside. So this is about a lady who's had renal transplant, so she was mostly bedridden. She developed a subacute dementia. And then later it was found to be cryptococcal infection, and the serotype was almost same with the cockadoo bird that they had in their house. So this shows that it is not limited only to pigeons, it can be seen in other droppings also. So this Cryptococcus, almost more than 50 species are known, but the two most important species is Neoformans and Gatti. It has been further divided into various species, serotype, and various sequence. Because of this division, there's a lot of genotypic and phenotypic variability. So why is all this so important? It is important because we know that for the fungus, it is the cell membrane that is very important for the management. The ergosterol that is present in the cell membrane, this is the site where amphotericin or fluconazole link and then further develop its mechanism of action. Even for flucytosine, it has to get attached to the cell membrane. Although its mechanism of action is little different, it attacks on the DNA and RNA. So uh, in those fungus where there is reduced ergosterol content or where there's a change in the cell membrane layer, these drugs will not work. This is the reason one of the microbiologists said, I gave my patient 3 cycles of amphotericin and still my patient died. This disease really amazed me. So he thought that why not develop antibody for this infection rather than we're treating it. So going back to Cryptococcus has a capsule. Below the capsule has a cell wall which has many particles. Each of these particles has a very important part in the pathogenesis. And then we have the membrane, which is a very important site for the drug action. So these are small oval cell, 4 to 10 micrometer. They usually divide by narrow base budding, okay, and they form these halo yeast cell on Indian ink. So what about this cryptococcal make it so virulent? Number one is the capsule. So we will be talking about the capsule maximum. Number two is melanin. The ability of this cell membrane to develop melanin is very important to make this cryptococcus stay strong in our own body. The ability of it to survive at very high temperature, various enzyme that helps in degradation of the endothelial cell, and its ability to survive and divide in the macrophage. I think this is one of the very few pathogen that where the virulence factor has been compared, and they found that it is the capsule and the ability to produce melanin is two main important virulence factor. So looking back first at the capsule. So what is this capsule? This is just a thick layer of polysaccharide that is surrounding the yeast cell. So the yeast cell has certain fingerprints. These are called as pathogen associated protein. These are the protein that when is exposed to immune scanner of our body, these immune scanner, that is the protein recognition receptor, they take it to our innate immunity and they activate our immune response. But the sad thing about cryptococcal is that these fingerprint, they are covered by this thick capsule, which is poorly immunogenic. In this way, so this presence of this capsule makes it antiphagocytic, inhibits the antibody production. Secondly, this capsule also helps the cryptococcal to live in very strange behavior. We know that brain is the most favorite place for this organism to want to live. But the brain is not very favorable for this organism because it has lesser glucose, lesser oxygen. But this capsule there plays a role to make it wants to stay there, neurotropism. Secondly, the melanin that is there in the cell wall. This melanin, it protects the fungus from oxidative stress. Other enzymes like protease, phospholipase, they break the endothelial cell, they degrade our host protein, and they allow this fungus to invade the cells. So this capsule, it's very dynamic. Even the fungus itself is dynamic. The capsule may enlarge, the capsule may small according to the need, according to the need of the fungus to shield itself. But the cell also becomes big. So this dynamicity of this cryptococcus make various phenotypic variation. So when the cell is very big, we call it the giant titan cell. And these giant titan cell are associated with more worse symptom, resistant and raise ICP. When the cell is very small, it's called titanites, and these are the cell which inhale by aerosol. So the variation of this capsule and this organism to make small and big makes it sometimes very difficult infection to be treated by us clinicians. So we say the capsule is so important, but there are cases report where case has been reported that there is a capsule deficient cryptococcal meningitis. So these capsule deficient cryptococcal meningitis are usually very mild in symptom. As we know, the capsule is the one that is the main virulence factor. So there are cases like this that has been reported also. Then second phase is after we inhale these yeast cells. So after we inhale this yeast cell, they enter into the alveolar macrophage. Before they enter the alveolar macrophage, these yeast cells have to survive that stage where there's a very high CO2 retention, CO2 concentration. The ability of this yeast cell to survive there also shows the capsule is so important for it. Then it is engulfed by the macrophage. After it engulfs by the macrophage, its ability to survive and divide within the macrophage. This is very important for the pathogenesis. It's not only important for the pathogenesis, it's important for responsible for something called incubation period. So this becomes an intracellular organism, and this is one of the main reasons why antibody cannot be developed against this pathogen. After it divides in the macrophage, this macrophage goes on from one organ to the other organ. So it acts like the Trojan horse. It's similar to tuberculosis. And then suddenly, when the macrophage is full, the macrophage will then expel the yeast cell. So this intracellular macrophage division is very important, and it's the one of the responsible factor for the lethality of this disease in humans. So this, after it being ingested by the macrophage, it can either send the organism from one cell to another cell, or it can expel, killing the cell or without killing the cell. So if you see this video here, this is a cell to cell transfer. So one macrophage is transferring the organism to another. So this, it has expulsed and then it killed itself. So this is called the lytic exocytosis. The third one, we can see the fungus dividing within the macrophage. After the fungus has divided and is full, and then it goes into exocytosis. But after exocytosis, the cell is left behind. So this is called the non-lytic exocytosis. So it's a very beautiful video. So now after these cells come into our body, what does our body do? So for us to fight this illness, we need the CD4 or the helper T cells. So the helper T cells, there are two helper T cells. One is the Th1 and the Th4. The Th1 is responsible for protection against this infection. This helper T cell will release certain cytokines like interferon alpha and tumor necrotic alpha, which further stimulate the protective macrophage. That means it kills the cryptococcus by itself. Other things also favor almost the same thing, other than natural killer cells, which is one of the cells that help to really kill the cryptococcus directly. But in patients where the CD4 cells are poor, then comes a non-protective, the cytotoxic T cells, the release of certain cytokines which activate the protective macrophage. These are called protective macrophage because it allows the fungus to survive and then form the Trojan horse. So this happens when our immunity is poor. So it can be either in AIDS or it can be in those conditions where T cells are being depleted, be it an organ damage or being an organ transplant, any other autoimmune disease, or any chronic use of any biologic drug or immunosuppressor. Now, the very interesting thing about cryptococcal infection is that in patient where there is less helper T cells, so there will be no inflammation. When there is no inflammation, the cryptococcal grows abundantly, it becomes uncontrolled. But when there is a lot of inflammation, the cryptococcal doesn't grow. So we see here that inflammation helps in cryptococcal clearance. That's why use of steroid in cryptococcal meningitis has to be done with a pinch, because this can worsen the prognosis. We need to know why are we using steroid. In fact, people have even tried that if we do the T cell mediated therapy, giving our patient interferon alpha or tumor necrotic alpha to increase the inflammation, it has shown to have a better prognosis, reducing the mortality. So here we need to understand how steroid need to be used very carefully in cryptococcal meningitis. So regarding the antibody formation, so the doctor I was telling you about was Arturo Castel. When he saw this person who died after 3 sets of amphotericin, he was very upset. So he wanted to take the study on antibody formation. But sadly, this antibody formation, it never came into existence. It got stopped after phase 1. But what he learned over the years is that this antibody response is there. Even there are many studies to show that antibody response is there, but this antibody response is very selective. It depends on isotype. Little change the polysaccharide, little change the formation of the wall, the antibody will not work. This IgG will not work for that serotype. Secondly, they noticed that antibody here required T cells. So it really, makes us question the humoral immunity against cryptococcal infection. So what we understand till now is that innate immunity or T cell based immunity works more here rather than a B cell. Coming to clinical manifestation, it can involve few organs. Number one is the skin. I would like to talk because I found it very interesting. So the skin lesion is usually this umbilicated skin lesion. So the lungs, we all are exposed. Usually we're asymptomatic, but it can be symptomatic. Symptomatic is more in immunocompetent patient or the non-HIV immunocompromised patient. We can have the prostate, we can have the bone, but the brain is one of the area where cryptococcal loves to reside. And finally, it's one of the most highest mortality and morbidity region of infection. So when it comes to the brain, how does this fungus enter the brain? So we have already discussed about this Trojan horse mechanism. So there's a transcellular, a paracellular migration. This macrophage is being taken as normal by the brain, but when it enters inside, then it releases the deadly cryptococcal. Second thing, what is that in the brain that make it favors the brain? So number one is certain enzymes that is there in the cell wall that helps in breaking the endothelial cells and allowing it to penetrate the blood-brain barrier. The most one of the important thing is that this autophagy, cryptococcus itself induce its killing under stress condition so that the nutrients and you can be recycled to keep the cryptococcus alive. And the third thing is presence of certain special transporter. Even in the presence of low glucose, this cryptococcal can survive with the help of these high affinity sugar transporter. So when it enters our brain in the subarachnoid space, so it releases the amount of polysaccharide antigen into the CSF. This activates then our innate immunity, and this then leads to a lot of inflammation. So when these capsule comes, they obstruct the arachnoid villi. This is the reason why raised ICP is one of the most important clinical feature in cryptococcal meningitis. So here we see when we perform a CSF, we get a very low glucose in cryptococcal. We need to understand that this fungal love glucose. So it consumes a lot of glucose. It has this high affinity transporter, and also the inflamed blood-brain barrier then impairs the glucose transport. There's a lot of protein, there's recruitment of inflammatory cell and raised ISP as we've discussed. So looking at this study, just like Dr. Angel said, over the years, if you see, the number of patients has been more of the non-HIV patient. This is because of the ability of the patient to survive with malignancy. This is because of the use of immunosuppressant in various disease. This is because of a very good organ transplant survival that we are having. So these are the disease that is usually associated comorbid other than an HIV patient. So what is the difference if it's HIV and non-HIV? So in HIV patient, usually the duration is 3 to 4 weeks, the symptoms, median symptoms. And the most important thing is that in HIV patient will come more with feature of raised ISP. But in the non-HIV or in the other immunocompromised patient present more with focal neurological deficit like a hemiparesis, more of respiratory symptom, more of cutaneous symptom. So this is something that we need to understand. When it comes to HIV, till now, cryptococcal is one of the leading cause of death, responsible for 19% of all HIV-related death. In India also, till now, in HIV patient, India also, cryptococcal still is the most common cause, leading cause of death. But it is noted that in Indian, there's an increasing proportion of non-HIV cases. So this makes us to be, we have to be aware, because usually when a non-HIV patient walks in, we don't even think of doing a cryptococcal infection. Only when there's certain symptom like very raised ISP, severe headache, a very low sugar, then we think of cryptococcal infection in non-immunocompromised patient. So what about the neuroimaging? Is it very important? Is it necessary? Yes, it is important. The British Society of Medical Mycology recommends us to do a contrast CT, not a plain CT, within 48 hours, especially in immunocompromised patients. We can have various findings. We can have features of meningitis. We can have a hydrocephalus. We can have cryptococoma, or we can have the pseudogelatinous cyst. The difference between immunocompetent, usually cryptococoma is more in immunocompetent. Immunocompromised, they just form this pseudogelatinous cyst, which is basically dilated Virchow-Robin space. Then we have this dirty CSF, which is a very important feature. This is a feature of very high cryptococcal antigen, cryptococcal infection burden, dirty CSF. So these are the radiological finding in neuroimaging. Now, after we start treatment, how to follow up, what to monitor, since treatment will be discussed later. So I'm going into the other part. So initially we need to see for ICP, we need to see for new neurodeficit, we need to monitor the drug toxicity. But after 4 weeks, it is very important for us to show the response to treatment. Usually, sometimes we forget to do this, but this is very important because this will help us to differentiate whether it is a relapse or whether it is a non-responsive cryptococcal infection. Later, over the years, it's only the renal and the liver monitoring and the rehabilitation support. But this shifting from induction to consultation phase is very important, that we prove that our previously positive culture or antigen or titer becomes negative. This is also important because if your patient comes with increased symptoms, you need to understand whether it's iris or whether it's just a relapse or improperly treated cryptococcal infection. So these are the things that we face when we see a cryptococcal or after we treat a cryptococcal infection. One is a persistent infection. Probably your patient is having resistance to amphotericin. That's why the best drug combination is amphotericin with flucytosine. But flucytosine being not very available at every state, first thing. Second thing, it has to be taken 4 times a day, making it very uncomfortable for the patient. The next important thing is a relapse infection. So for relapse infection, it's very important that you have to show the viable cryptococcal from a sterile area. Then we have certain complications like raised ICP, cryptococoma, hydrocephalus, infarct, and neurocognitive impairment, seizure, and cranial nerve dysfunction. Iris needs a very important understanding because there are 3 types of iris with cryptococcal meningitis. Number 1 is a classical cryptococcal iris where you treat the patient and you prove that the patient has cleared the organism, and then later when the immune is restored, your patient comes back with increased symptom. This is because of cytokine surge and needs to be treated as inflammation rather than a fungal disease. The second is unmasking iris. This is in a patient who is receiving ART with no symptom of cryptococcal, then develops cryptococcal infection. So this patient needs to be treated as a new cryptococcal infection. And the third is the post-infections infectious inflammatory response. This is usually seen in immunocompetent patient and is quite similar to the classical cryptococcal iris seen in immunocompromised patient. This also needs to be treated with anti-inflammatory. So, looking at the mortality and the morbidity, we know that the mortality is very high in cryptococcal despite treatment. So, what are the various factors that help us to decide that mortality, predict? So, one is the CSF pressure. If it's very high, if it's a very high titer, so this will tell us that your patient will have, a very slow fungal clearance rate. Then if there's a delayed diagnosis, that is very important. Among the immunocompetent, if your patient has a predominant absence of headache or a very low CSF cell count, just show that there's very poor inflammatory response. So these are the two factors that can predict your patient's outcome. But for improving the outcome, it's very important to go for the best combination of drug, number one. Number two, it's very important to start ART as soon as possible in the HIV group of patient. So this treatment will be discussed. I just kept this slide because I found it interesting. So as I said, the flu cytosine has to be taken 4 times a day. So the single dose liposomal, this is very good. But now studies are coming up. What if we make this flu cytosine a little modified release? So it has to be taken only twice a day rather than 4 times a day. People are coming up with new antifungal. People are coming up with an oral amphotericin. So people are working hard to make the treatment easier for cryptococcal infection. What about its prevention? Prevention has no definition in immunocompetent patient, but in immunocompromised patient, when your CD4 count is less than 100, you have to screen your patient for cryptococcal. And if they are positive, despite being asymptomatic, you have to treat them before invasive cryptococcal infection develops. So with this, I would like to end my slide. Thank you.
Thank you, Dr. Beka. It was
Yes.
wonderful. Your lecture was wonderful, very informative, and you covered most of the things, especially pathogenesis, which I could understand for the first time. Wonderfully done. All the best.
Yes, sir.
Thank you, ma'am. That was a very good, comprehensive talk on cryptococcal meningitis and the pathogenesis. Now we'll move on to the next part of the discussion.
Are my slides visible?
Yes, it's visible.
So, good evening, everyone. Dr. Baya has talked extensively on the pathogenesis of Cryptococcus. So, I'll be talking about the advances in the diagnosis of Cryptococcosis from India Inc. to rapid antigen detection. So, as we all know, the diagnosis of cryptococcal meningitis has changed dramatically over time. Fungal culture of the CSF has historically been the gold standard for diagnosis, with India Inc. being an essential adjunctive to the modality for decades. However, people with lower fungal burdens, they present a significant challenge to the diagnosis, as they can be missed by both. So before I go further to the diagnosis, I would like to talk a little bit about sample collection. Most of the samples, if it's skin, then you have to collect skin, but if it's a cryptococcal meningitis, then we collect either blood for blood culture and, most importantly, CSF. So a little bit about the CSF, because how the sample is collected is very important. So CSF is usually collected using lumbar puncture, in which the patient is placed in lateral decubitus position, and then the L3, L4 interspace is usually located Then upon location, then the area has to be cleaned properly with iodine and then followed by alcohol and then draped, after which the lumbar puncture needle is inserted aseptically into the L3, L4, or L5 region, after which the CSF is usually collected into 3 or 4 sterile tubes. Now, while doing a lumbar puncture, we can come across something known as a traumatic tap, which we have to differentiate from an intracranial hemorrhage. So traumatic taps, if we is differentiated in that, in traumatic tap, we see the blood cells are present in decreasing consistency from the first tube to the last tube. Whereas if it's an intracranial hemorrhage, then the blood cells will be distributed equally among all the 4 tubes. Now, coming to the tubes, we need to know which tube that we have collected has to be sent for what. So the first tube is usually sent for biochemistry, as it has, in case of traumatic tap, then it has more cells, so it might alter the cellular count later. And then the second tube is usually sent for culture because it has a larger portion of the total fluid concentrated. So therefore, it facilitates the detection of infectious agents better. And the third and the fourth tube can then be sent to for the cellular counts. So the most important thing when it comes to microbiological diagnosis of CSF is the transport of CSF. So if you're sending it for microbiology tests for culture, it has to be transported immediately. Specimens for microbiology studies, they should never be refrigerated because in case it's not Cryptococcus, in case it's some other bacteria, then they would die off if we refrigerate it. So CSF, if it's not processed immediately for culture, it should be either incubated or it should be left at room temperature. However, if you're going for viral studies, then you can refrigerate the CSF for at least 23 hours. But if you're expecting a longer delay than 23 hours, then you have to store the CSF at minus 70 degrees Celsius. Now, if it's not processed immediately, if it's the CSF is for hematology studies, then you can refrigerate it. And if it's for chemistry studies, then you can freeze it at minus 20. Before we process, there's certain initial processing of the CSF, which involves centrifuging. Now, centrifugation is required if we collect more than 1 ml of CSF, during which you will get a supernatant and a sediment. However, if we have just less than 1 ml of CSF, then we have to process the CSF as it is. We can't centrifuge it. Now, the supernatant can be used to detect the presence of antigens for rapid diagnostic tests or for chemistry evaluation. But for culture, we need the sediment. So coming to the culture methods, the most important is culturing it in Sabouraud's dextrose agar. However, if it contains cyclohexidine, it will inhibit the growth of Cryptococcus. So we have to make sure that the Sabouraud's dextrose agar that we're using does not have cyclohexidine. Now, into this agar, we just add 2 drops of the sediment and then we incubate it at 30 degrees Celsius for 4 weeks. But usually the Cryptococcus would grow around 3 to 7 days. However, we can have false negatives in cases in which the fungal burden is very low. So this is what Cryptococcus looks like. It's mucoid on Sabouraud's dextrose agar. Now, in case we've collected blood for blood culture, then we can inoculate it into the biphasic media, which would contain BHI broth and agar. Now, the importance of a biphasic media is that it prevents contamination. So you can incubate it for a long time, and if you want to inoculate it into the solid media, you just tilt the bottle, and you don't have to open and expose the media to the air, which will easily get contaminated. Once growth is seen on the solid media, you can confirm whether it's Cryptococcus by doing gram stain, in which you will see round yeast cells which have broad-based budding. And furthermore, we can identify Cryptococcus by the various, as we remember from Dr. Baya's lecture, the various virulence factors. So the melanin would make the Cryptococcus grow dark dark brown if we use Niger seed agar or bird seed agar, and it grows at 37 degrees Celsius. And the urease can be tested by a urease test in which it would come positive, and we can further test for assimilation to speciate the Cryptococcus. Then coming to India ink. India ink is less time consuming as compared to your culture. So it is direct visualization and it decreases the time for diagnosis. So we take a drop of CSF sediment and we mix it with 1/3 of volume of India ink, and then we place a cover slip on it and we just observe it directly in the microscope. So here we see the polysaccharide capsules. Now this is a form of negative staining in which the background stains dark, but the capsule and the yeast does not get stained. So you see that the capsules stand out. However, there's a study in Uganda where the prevalence of Cryptococcus is high, and the use of India ink as the only diagnostic test had the potential of missing around 8.8% of cryptococcal diagnosis. So India ink, even though it is less time consuming, cannot be used on its own for the diagnosis of Cryptococcus. Then now we come to cryptococcal antigen tests, which due to the many limitations of the culture, now this has become a new gold standard for diagnosing cryptococcal meningitis, and it is recommended by WHO as the first diagnostic test. Cryptococcal antigen test is used to detect antigens both in blood as well as CSF. It can use it can be used differently and uses different modalities. Some use latex agglutination, some use ELISA enzyme-linked immunoassay, and some of the tests are lateral flow assays. But they all have a sensitivity and specificity of 99.1% to 100 when we use to test the CSF, not to the blood. The CSF has higher sensitivity and specificity. Now, ELISA and latex agglutination assays have shown major improvement in terms of sensitivity and specificity. However, they still require a cold chain for specimen transport, and they still require technical expertise, and they still require a laboratory. However, the lateral flow assay, one of which has been used a lot, this IMI, it is FDA approved, and it has been validated in multiple clinical studies, and it has emerged as a new gold standard because it is a very simple test. So you just add a drop of the diluent, and then you add the sample, insert the strip, and then you just wait for 10 minutes. And then if you see a control in a test line, it's positive, but if you just see the control line, it is negative. The advantages of this lateral flow assay is that it's rapid. It takes just 10 minutes for turnaround time. It's cost effective. It requires minimal training and laboratory infrastructure. There is no need for refrigerated storage, and it has a higher clinical and analytical sensitivity. As we can see, the sensitivity and specificity, as I've said, for any is higher when we use it for CSF rather than for serum. However, these antigen tests, they have a they have a limitation. There's certain phenomenon known as the prozone or the post-zone phenomenon, in which if there's excessive antibodies or excessive antigen, they might come as false negatives. So this is one thing that we have to, if we see it's negative, then we have to dilute the CSF, and then we will have to look for the cryptococcal antigen. Then coming to the 1,3-beta-D-glucan test. Now, this has a lot of pros and cons and a lot of debate, but it's a non-specific fungal marker, and many have said that Cryptococcus releases a very low level of beta-D-glucan. But beta-D-glucan levels in the CSF, there have been many studies which have studied beta-D-glucan test when used in serum, but they have seen that if it's used in the CSF, it has a higher sensitivity, and this sensitivity, one thing about the beta-D-glucan is that the level normalizes rapidly. Once the patient is treated, the beta-D-glucan decreases, unlike the cryptococcal antigen. So it's used for diagnosing of recurrent episodes. However, when we use beta-D-glucan, we have to remember that it has a high false positive rate, because we can get false positive just from bacteremia or hemodialysis or IV immunoglobulins, even antibiotics like your beta-lactam antibiotics, your piperacillin, tazobactam, or amoxicillin can give a false positive beta-D-glucan, and other medications containing lentinins, schizophyllan, and scleroglucan. Lastly, we come to the modality that we use in each and every infectious disease nowadays is your molecular tests. Now, molecular testing has emerged as an alternative diagnostic modality. However, like most of the tests, it is limited by the poor sensitivity in individuals who have low fungal burdens. Now, the BioFire film array has added Cryptococcus on its panel on molecular diagnosis. However, molecular tests will always have one limitation, in which they are very expensive, and so the cost effectiveness is not very good for molecular tests. And with that, I come to the end of my lecture. Thank you.
Thank you, Dr. Ringa. That was very nice and crisp way of putting the necessary diagnostics. May I invite some comments from Ravindra sir regarding the.
I would just want to ask, do you recommend that every CSF, if there is a suspicion of meningitis, be subjected to India Inc?
Sir, India Inc., we can, but we can just depend on India Inc., sir. We have to send it for culture. Culture has to be the ultimate.
But for screening and for initial diagnosis, because many times these lab facilities are not readily available.
Yes, sir. So yeah, we can depend on the India Inc., but like I said, you can start the treatment, but to confirm it would have to.
If it comes negative, then still go for the advanced test.
Yes.
But then you recommend that India Inc. should be done routinely in each and every.
Yes. But like I said earlier, it should not be the only test. It should be done within.
Thank you.
So I think Indian Ink is being sent as a routine investigation. Usually when we send our CSF, one is still AFB, gram stain, Indian Ink still goes in one of the pile. But yes, very true, Indian Ink hardly detects. I think it really detects when the fungus growth is, the fungal, this thing is a lot, I think.
Yeah, it depends on the burden. It depends on the burden. If the burden of, if it's less.
Many times, India Ink preparation comes positive, then you know that your patient is having cryptococcal meningitis.
Yes, because the load is very, very high.
Thank you.
So, of late, we've also had instances where, patients hardly have any much of systemic symptoms, but just come with features of raised ICP. And then we do a CSF and you find the opening pressure is very high, immunocompetent. And then we send for all the counts, and that itself counts are high and lymphocytic. And then sometimes when they're seeing the counts itself, they report, the yeast-like organisms are seen. So that is in, people who are trained to see and report cell counts. It's easier to, pick it up in such when especially like you said, the volumes are high. But of course, we have actually in our center, we've incorporated it as a standard, for any meningitis, be it acute or chronic. We actually send cryptococcal antigen at least from the serum, because as ma'am, Dr. Baya correctly said that it's always a cryptococcemia which precedes the CNS symptom. So cryptococcal antigen has to be positive in the serum before even it manifests as a thing. This rule is valid, very valid for immunocompromised, because that is why recommendations say it can be employed as a screening test. If your CD4 is low, if you want to know this patient is harboring cryptococcal, you send an cryptococcal antigen. If it's positive, you actually start treatment. You don't wait till they develop meningitic symptoms. But currently, the level of evidence is very low to use that in competent as well. But it's definitely a part of algorithm in those presenting with subacute to chronic meningitis in our center. So, any
think
other
that
comments?
the clutch point will be the headache. I
Yes.
feel like if a patient comes with features of very severe race ICP, nothing. Usually, it's always cryptococcal. I don't know what does Girk sir says from his experience.
I have a lot of experience with tuberculous meningitis, but tuberculous meningitis, headache is not that problem
Yes, sir.
as it in cryptococcal meningitis. Excruciating headache in setup of meningitis has to be considered the possibility of this cryptococcal meningitis. If you have suspected meningitis and patient is having severe headache, think of cryptococcal meningitis.
Secondly, Dr. Angel, as I was reading, this guideline is only for immunocompromised CD4 of less than 100, and we go for serum test. But I feel that if our patient is a non-HIV immunocompromised, be it anything idiopathic or depletion, or we should go for a CD4 cell count, because nowadays even TB protection treatment has been initiated for the immunocompromised patient, anybody who is on any immunocompromised state, be it drugs, because we use a lot of drugs nowadays for NMO, for myasthenia. So
Yeah.
I don't know whether CD4 cell monitoring is important or not in our patient, our set of neurological patient who are on immunosuppressants.
That's a good thought, ma'am. In fact, most of our cryptococcal meningitis, we also look for presence of T cell immunodeficiency. In fact, we do the CD4, CD8 subset because whether they have this idiopathic CD4 lymphopenia, because we know that T cells are the main immune defense mechanism. Surprisingly, I think out of at least offhand, if I remember, out of 5 patients we tested, one had a CVID, like a late onset combined variable immunodeficiency, and both B cell and T cells were not there. And the others were actually normal. So, but we do see them coming from northeast, the belt, especially in that region, northeast, Uttar Pradesh, and the regions surrounding, those areas. I'm not sure whether it's directly related to the amount of vegetation, tall trees, whether that is actually harboring these spores, and there is increased environmental presence, hence we are seeing a lot of cases. We actually tried mapping them, and here also in Tamil Nadu, there are some pockets where we see a lot of cases which are coming from. So next step is to figure out what in the environment is predisposing to the occurrence of these spores, because again, with increasing temperatures, whether these spores are thriving a longer and increased humidity, again, it's a part in the northeast, it's more, most of the times it's wet, humid, which is ideal for fungus to grow. So it's quite an interesting disease. But other important thing to bring up is the in immunocompetent patients, we see this PIRES, we call it post-inflammatory immune response, where once you start treatment and you actively reduce the antigen load, that is when your immunity spikes, immune response spikes, and they behave like, sort of TB iris, sort of, they become very sick and raised ICP. So again, steroids at that point is very, very important. Steroids, and, don't stop the antifungal. Continuing steroids is also a important point that we have to note.
I think in immunocompetent, it's not really a difficult decision to decide on iris, be it
Yes,
TB or
yes.
cryptococcal. The problem is immunocompromise.
Yeah.
When you're really not sure what other infection is the patient having. Sometimes you cannot prove TB and you're very confused what is it, or you cannot prove any other virus or any other fungus because we know that it's layering is very common in in immunocompromised patient. But recently we had one patient who is a known case of sarcoidosis and landed up with a hydrocephalus. Finally, the diagnosis was cryptococcal, but sadly, despite good liposomal, despite good flucytosine, despite good fluconazole, patient could not survive. So hydrocephalus became bigger and bigger. Then we did the CD4 cell. Initially, we blamed to sarcoid, taking steroid. Then we did the CD4. CD4 was very less. So now we are very confused whether that is an idiopathic, some variable immune deficiency disorder, or whether it is sarcoid itself attacking the bone marrow, the brain. So these diseases, these type of patient, finally the patient succumbed to his illness. It was a very long fight for us, for him, but we could not save him. So that was a very boggling case, eye-opening case. So as how this infection is so naughty and
Okay, so any further comments from the moderators, panelists? We can, if there's any question from the audience, you can put it in the chat box. We'll be happy to discuss any specific questions or comments. So how often do you see, ma'am? Do you see quite a big burden of crypto in your center?
Yeah, over the years, I feel one thing is that patients are coming. Patients have started being aware of medical illness. Otherwise, people from village, they won't come. So now, recently also, we've diagnosed a number of cryptococcal infection, but most of them are associated with immunocompromised state. One thing is the detection of, maybe ICTC, that is so same like the older 1983 when ICTC came, then cryptococcal rose. I think the same thing is coming here. So yes, we do have a lot of challenge treating them because they do not respond very well with the full dose ampho also. And secondly, like flu cytosine is not affordable, it's not easily available, so we are not able to give the combo to them. So it's some of them cannot afford the liposomal. We have to give the normal ampho, which leads to a lot of toxicity. But still, we are treating them. Mortality is there, but I feel the mortality in our patient after treatment is usually in the future, like over the 1 year. It's not like immediate mortality. I feel like a cryptococcal patient, if gets immediate treatment, immediate detection, that early mortality is not there. But definitely over 1 year, on and off, something happens which leads to mortality. I don't know, Garg sir, how is your experience, sir, over the mortality of cryptococcal?
As far as mortality is concerned, if you treat early, you can stall mortality.
Yes,
death.
can stall.
But most of the time, their rest of life remains miserable.
True, very true.
And many times they present recurrently. They present with headache, and you perform, and again this antigen was positive, and you treat again, and ultimately most of these patients have not a good prognosis.
There is one question from the audience. He wants to speak. I'll just allow him to talk. Yeah. Yes, Dr. Deepa and Bishwas, you can unmute yourself and ask your question, please. Are you able to hear us? Yeah. You're unmuted. You can ask your question.
Or we can just read his question out.
Yeah. Have you, okay, can you put it in the chat box? Yeah. So any Cryptococcus gattiae was seen among all these patients with meningitis, or was it all Cryptococcal neoformans? Yeah.
Maybe Dr. Davet can take that because we know only Cryptococcus, but the species is identified by our Indian.
I will take that. Currently, we're not doing the canvaline test, so we are not differentiating between the two Cryptococcal neoformans or Cryptococcal gattiae.
So we do see gattiae in our institution because we speciate, and we feel gattiae behaves much more severe to compared to neoformans, and gattiae also has a chance for delayed clearing. So because they need more prolonged therapy. As per guidelines, you stop at 2 weeks, they have a chance to come back. So it's very important to keep documenting clearance. So we need periodic, like anyway, they will require therapeutic LP. So every time you do a therapeutic LP, we usually keep sending to see whether the document the clearance, and we also go by the cell counts. But the catch with the cell counts again is because cryptococcal meningitis, lower the cell count is supposed to be associated with worse prognosis. So we cannot, go by cell count, especially for clearance. It has to be purely through smear on and the culture. So every time we need to, as and when you repeat it, we need to culture and document clearance.
So you're saying, Dr. Angel, that Gatti is associated more severe.
Yes,
Because
yes.
usually we say Gatti is more common in immunocompetent patient.
Yeah.
Right. Like what is traditional because we do not do the species identification. So
Correct.
from our point, we don't have experience on that. But it is very amazing that you're saying that it's associated with more of.
Yeah, but the commonest is supposed to be neoformans. So the Gatti is much more rarer. So I think the chance of us getting it is low. But if you get it, these are the things to be aware of.
I think India is endemic for both.
For
if I'm
both, yeah, definitely.
My question is, when should clinician ask for this species identification?
Yeah,
At
that's
what
a
point of
good
time?
question. So I think so that mostly depends on the lab expertise, because as the fact that if you're able to do the India ink and culture itself is a good level, which itself is not possible in many labs even at a tertiary level, district level hospitals. It's not possible. They have to send it to a higher center or a Sentinel center. So speciation is one more step ahead to recommend that. I mean, it's not, the management is not going to change. It's only the awareness that, okay, if somebody is going to be severe or the relapsing types, that is going to make the difference.
And India ink preparation differentiate species, identify species on India ink preparation?
No, sir. Both will, I think, yeah. Dr. Dabit,
No, sir.
Yeah,
It
yeah.
can't.
Yes, so there's another question, I think, in the chat
Yeah.
box. The question is saying, is there any occupation is there any specific occupation which increases the risk of the disease? So maybe she's talking about healthcare profession. I don't know, because when it comes to human doesn't spread the infection any further.
Yeah.
So
No, any particular
risk.
I think most people who come in contact with this dead matter, the usually
forests or
going into the foresters, dwellers, agricultural workers, and another catch is, in fact, cryptococcus also been reported from very dense populated places where there are, instead of trees, you have like tall buildings, which again is an excellent roosting place for these birds. So urban, these urban pockets where you have very, medium to tall buildings, apartments which are not tended to. So that is why periodically they keep cleaning. Even in hospitals, you see, there are places where there's a lot of pigeon poop, but it's the catch is not all pigeon poops are dangerous. In fact, pigeons are natural excretors of this fungus, and they are very well. It's not like they succumb to this disease. It's like how bats coexist with Nipah, and they are perfectly fine. So it's more of a spillover, and the amount of inoculum which you take decides how much disease you get. So
Lucknow is area where there are a lot of pigeon lovers.
yes.
They have a lot of pigeons, and with morning they free all these pigeons, and by evening they come back.
yes.
Yeah. And anyhow, I have hardly seen any cryptococcal meningitis in so-called pigeon lovers.
Yes.
Yeah.
So I think it's more related to chronic accumulation. Though they excrete it in the poop, they need a medium to survive, grow, thrive, and so.
The
Genetic
soil is the best.
genetic susceptibility is also plays an important role, and having this invasive cryptococcosis? Possibly, genetics plays everywhere a role.
Yes, sir. I think studies are going on that, whether genetics is responsible for the invasiveness and for the resistant, the viral, resistant of the drug. So definitely in TB also, I think genetic plays a role.
So I think that brings us to a good discussion and the end of a seminar on cryptococcal meningitis. So we'll meet on the third week where we will be discussing the evidence-based guidelines as a part of the journal club. Where again NEIGRIHMS team will present, and we'll have Dr. Selva Kumar from CMC Vellore, who will be moderating the guidelines session. So thank you, sir, and thank you, Dr. Baya and Dr. Dabit. It was a good discussion, and thank you so much for your time and effort. Yeah.
Thank you.
Thank you, sir. Thank you, Dr. Thank you, Dr. Dabet.
Thank you.